Welcome to the Mayo Clinic Cardiovascular Masterclass.
I'd like to speak to you today about pacemakers, ICDs, and cardiac resynchronization therapy. I have no disclosures. Let's review now the indications for cardiac resynchronization therapy and select appropriate patients for this intervention. Cardiac resynchronization therapy has become a quite mature therapy for congestive heart failure in the setting of advanced left ventricular systolic dysfunction and a left bundle branch block pattern of ventricular activation that is associated with desynchronous activation of the left ventricle, such as illustrated on the left movie, where you see the septum activated first, followed by the lateral wall reflecting the right to left motion of the depolarization wavefront from the right bundle to the lateral wall of the left ventricle, since the left bundle is not working. And in these patients, the placement of a coronary sinus lead with the intention of providing lateral left ventricular activation at the same time as septal activation is associated with narrowing of the QRS, a change in morphology reflecting the union of the left bundle branch block pattern of activation with the right bundle branch block pattern of activation provided by the coronary sinus lead, such that we have a resynchronized heart, a narrow non-left bundle QRS associated with, in this case, a substantial increase in left ventricular systolic function. And so indeed it is left ventricular dysynchrony and its treatment that is the rationale for cardiac resynchronization therapy. What is left ventricular dysynchrony? Well, left ventricular dysynchrony is the temporal dispersion of regional left ventricular contraction. In other words, it's the replacement of rapid, symmetric, His-Purkinje-mediated activation of the heart by a slower right-to-left depolarization of the myocardium, such as what one would see with left bundle branch block, an intraventricular conduction defect, or RV apical pacing. Now, the consequences of left ventricular dysynchrony physiologically include the following. You have early and unloaded ventricular septal contraction. You have a reduced rate of intraventricular pressure rise and a lower systolic blood pressure. You have a prolonged pre-ejection interval and a reduced ejection time. You have a reduced diastolic filling period. You have worsening of mitral regurgitation due to discoordination of papillary muscle function. And together, all of these pathophysiologies culminate in LV dilatation and a decrease in ejection fraction. Now, the foundational CRT trials have shown several important results that I'd like to summarize. In terms of clinical benefits, several improved quality of life measures have been documented and a reduced burden of congestive heart failure hospitalization. CRT reduces mortality with a greater mortality benefit associated with the provision of defibrillator therapy compared to pacing, but even with CRTP, a mortality benefit. Reverse remodeling, so the ventricle shrinks and it squeezes better, typically measured by a substantial, greater than 15% decrease in end systolic volume. And uniquely, this increase in left ventricular systolic function occurs with no increase in myocardial oxygen consumption. Now, it's important to understand the evolution of the foundational CRT trials because it allows us to remember easier which scenarios allow for CRT and which ones don't. So the initial validation of CRT included patients with class 3 to ambulatory class 4 heart failure. They had an ejection fraction less than 35% and a QRS duration greater than 120 milliseconds, and benefit to heart failure hospitalization and mortality was shown. More recent trials have extended the CRT to patients who were less sick at enrollment, class 2 heart failure. And in those patients, the benefit of CRT was limited to those patients who had a classic left bundle branch block of whatever duration, or a non-left bundle IVCD that was particularly wide, greater than 150 milliseconds. And the CRT response that you can anticipate for your patients is about 50 to 70% in all these trials. So here's the table that we need to learn to know which patients can be offered CRT and which ones can't. And I would suggest that you draw a line here between class 2 and class 3 to help you memorize the table. If the patient has class 3 or ambulatory class 4 heart failure, All you need is an EF less than 35% and a QRS duration greater than 120 milliseconds. All of these patients, left bundle, non-left bundle, QRS 120 to 150, left bundle, non-left bundle, QRS greater than 150, can receive CRT, the only difference being the strength or conviction of the recommendation from 1 to 2B. If we're dealing not with class 3 and class 4, but with class 2, then the patient who has a non-left bundle branch block ECG that is relatively short, not that long, less than 150 milliseconds, should not be offered CRT. If the patient has a classic left bundle branch block, 130 milliseconds, you can offer CRT. If the QRS is greater than 150 milliseconds, whether it's left bundle branch block or not, you can offer CRT to the class 2 patient, though the strength of evidence is greater for left bundle branch block. And in class 1 patients, the only group of patients to which you can offer CRT is the patient with a very wide QRS that is left bundle, and the patient has a very low EF, less than 30%, due to an ischemic etiology. And that subset comes from the MADIT CRT trial. Now, the guidelines identify a few other clinical scenarios where it's appropriate to think about CRT. If you have a patient who has an EF less than 35%, a QRS that is greater than 120 milliseconds for class 3 and class 4, but the only difference is atrial fibrillation, you can offer CRT. So if the table I just showed you is met by the patient, but the only difference is that they're in atrial fibrillation rather than sinus rhythm, you can offer CRT. Now, the guidelines use two different phrasings that I've placed on this slide for you to talk about the patient who has a conventional bradycardic indication for pacemaker therapy, but has left ventricular dysfunction. So here's one phrasing: the patient who requires chronic ventricular pacing, heart failure class not specified, but the EF is less than 35%, and you're anticipating that the patient is going to pace a lot, CRT can be provided. Phrased another way, you have a patient who has a need for a device for heart block, let's say, or a replacement device. They have an EF less than 35%, and again, you anticipate a high prevalence of ventricular pacing. CRT can be offered for that new or replacement device, and it doesn't matter whether they're in sinus or atrial fibrillation, and again, the congestive heart failure class is not specified. So the point is that the patient who needs pacing for a conventional bradycardic indication and has left ventricular dysfunction is going to suffer the morbidity of chronic right ventricular apical pacing, and it's appropriate to offer CRT to those patients. Now, I've modified this slide to acknowledge the publication of the Block HF trial in 2013, which is different from the 2012 guidelines in only one way. They recruited patients whose ejection fraction was not less than 35%, but less than 50%. They needed pacing for AV block. They had class 1 to 3 heart failure, and in those patients, CRT reduced the composite endpoint of death, heart failure urgent care, or an increase in end-systolic volume greater than 15%. Now, the FDA has approved this indication for CRT, but this trial has its methodologic problems that have been the subject of criticism. This subset of patients, less than 50% ejection fraction, has not evenly been offered CRT in clinical practice. And this trial has not yet affected guidelines. The most recent CRT guidelines were published in 2012. This paper came out in 2013. So in summary, for CRT, remember that the indication for CRT is based on an ejection fraction less than 35%, the associated heart failure class, QRS duration, and its morphology.
We hope you enjoyed this presentation.